this opportunity to welcome our colleagues for the next session, which is the immunology session. And I would like to invite Dr. Hadel Mursi, who is an immunology registrar, and Dr. Shuayb Elkhalifa, who is a consultant immunologist based at Salford Royal, Manchester. Thank you very much.
Well, thank you very much. Hadel, it's over to you to start.
Okay, hi. Assalamu alaikum, Eid Mubarak, and kul sana wa tayyibin. We are really thrilled here today to talk about the promising hope for treating COVID-19 infection in terms of convalescent plasma. We have a panel of experts. We have the hematologist, Dr. Harriet Lucero from Manchester joining us, and we have a panel of immunology consultants from around the globe, obviously Dr. Shuayb, Elkhalifa, but also we have Dr. Gehad ElGhazali, who's joining us from UAE. He's going to join us in a minute, and also Dr. Nahla from Sudan, and Dr. Amel Hassan, who's going also to join us maybe in a few seconds, if you just bear with us, from QATAR. So just a general outline for how it's going to be today. We are going to start first with a brief introduction about from the hematologist, Dr. Harriet Lucero. She will talk us about the practicalities of convalescent plasma with more focus about the trials here in UK. And then we are going to invite Prof. Gehad ElGhazali to take us through maybe more sort of mind grilling part, I would say, about neutralizing antibodies and the immunopathology of convalescent plasma. So in simple words, how does it work? And then maybe more aspects about passive immunization, because convalescent plasma is just one of these. And eventually a practical aspect, which is the potential, basically risks and safety issues by Dr. Nahla. And then we will go for a discussion where we will invite all speakers to let us know about the local experience in each country. And then we will welcome the floor for the questions from the audience. So please bear with us. I don't think we will be able to answer questions before the end, hopefully if we have enough time. And the mic is over to you, Shuayb.
Thank you ever so much, Hadel, for the kind introduction, and thank you ever so much for Sudanese Junior Doctor Association for hosting this webinar. And again, thank you for Dr. Abdalazeem for managing the whole program. So just to kick off straight away, it's my great pleasure to introduce my colleague, Dr. Harriet Lucero, who is an educational lead in hematology and transfusion lead in Salford Royal Hospital, as well as the trusted specialty training lead in hematology. Without further ado, it's just over to you, Harriet. Thank you.
Just a technical thing. I can't share my screen. Have you got my slides, or can you let me share it?
Yes, yeah,
Sure.
yeah.
Oh, okay.
Do you see the slides now?
Yep, thank you.
Okay.
Okay, so I'm just talking about the UK perspective really, and about sort of the practicalities of convalescent plasma. So in the UK, convalescent plasma is collected much in the same way as we collect our usual fresh frozen plasma that we use. Based upon sort of experience with SARS and MERS, and look at the literature, and then also the UK had the privilege of looking at what China did, etc. They decided that the best time to collect was about 28 days after recovery, because that seems to have the highest level of antibody titers, and we want to be able to collect plasma from donors on more than one occasion. We'll collect it by plasmapheresis. You can use the same donor more than once. And so this was thought to be about 28 days after recovery or after discharge from hospital. The UK donation criteria is just like it is for any other blood donation. So there's a simple donor questionnaire, which they have to complete, basically saying that they're fit and well and they've not participated in any activities that they shouldn't as such. And then there's the usual screening of the products for hepatitis B, C, E, HIV and syphilis. And there's no pathogen activation in keeping with the rest of our FFP use. Next slide. So in the UK, we usually collect FFP just from male donors. The reason for that is sort of the Charlie data that came out of the UK Haemovigilance and SHOT. And there's more evidence of Charlie using women's plasma basically because of antibodies after childbirth. However, obviously with COVID-19, we want to be able to collect it from our whole population. So there's checking of any women's plasma of HLA and HPA antibodies, and then anybody with a high titer would then obviously would then be excluded, unfortunately. And then also we're usually unable to donate if you've received any previous blood products, and that relates to the variant CJD. And therefore, if we were to continue with that, with the convalescent plasma, over time, you'd have a reducing donor pool. Because if you imagine patients have been treated, and then they've got antibodies, and then we can't use them again. And so, sorry, the slides have changed in the background. And so, go back one. No, never mind. Patients receiving convalescent plasma should be able, forwards again, should be able to continue to donate, and we're just looking to change our guidance on that. And then alongside this, just a safety precaution, the first 1,000 donations are also going to be screened for plasma for coronavirus RNA. One slide before, please. So the practicalities in the UK, we've got 23 static blood donation centres up and down the country, basically based in major cities. And we're continuing with those just for the collection of convalescent plasma, rather than using whole blood and then taking the plasma from this, such that we can use the same donor more than once, and it's a very consistent supply. We do know that this may exclude just a few of our potential donors due to logistics, but we're hopeful that given that they're up and down the UK, that we'll be able to collect from the vast majority of people that are eligible. And then next slide. So how we check the quality of our plasma in the UK, we use a neutralising antibody assay. It's done in our central labs in Public Health England laboratory. They use the neutralising antibody assay, and they measure the concentration basically based upon the plasma concentration that inhibits 50% of the SARS-CoV-2 growth. And they found they're using the top 35 to 40% of donations that involves a titer of greater than 1 in 100. It's similar to the plaque reduction neutralization test, but it's not comparable in terms of its measure, which is relevant, I think, to our international audience that might use different assays for that. Next slide. And then the UK trials. I've not put much on the slide for this as such. The REMAP-CAP is a large international trial which has a pandemic arm, which we're using in the UK along with many other countries, and it involves adults that are already in the ITU setting. They have to be within 48 hours of their ITU admission, and they're given plasma on days 1 and 2 of the study. And then that's compared to a control arm in a 1-to-1 ratio. And then they're collecting data based upon the number of days without needing additional organ support is the primary endpoint for the pandemic arm of that study. They're also collecting a lot of secondary data based upon thrombosis and other serious adverse events. And then within that, they're also doing a quantity of measuring blood parameters intensely on the first few patients, checking cytokine levels amongst other things, and to check the patient's own antibody levels, etc. And then just opening up now is the recovery arm, and that's for any patients that are in hospital, and that would then also include neonates and children as well as in hospital adult patients. There's a lot of thought that maybe REMAP-CAP might be a bit too late, because by the time they're in intensive care, potentially the patients have already developed their own antibodies at this stage, and the plasma might not be of the most benefit. But these patients are very intensely monitored and will be able to pick up on any side effects. And so it was thought this would be the arm to open first from a safety point of view. And as I mentioned, the recovery arm is just starting up now. Next slide. And that's it. Thank you. Just a quick tour.
خلاص تمام أنا داخل. Okay.
Thank you.
Many thanks very much. Harriet, this is great. I think this is exactly just a kind of a start of what we're doing here and the trial in the UK, and obviously the REMAP-CAP study, which we know is across the globe. If you're going to be with us for the later discussion, that would be great. If you can't, it's absolutely fine. So we can catch up with you later. Any question we have got right now, or shall we move to the next speaker? So I've got a question here. What's the role of plasma in the treatment of COVID-19? Are we going to take this question now, or
I think Shuayb, we might leave the questions until the end of the all host sessions, because you might well have your answers within
at the end of the discussion.
yeah, within the next
Okay, well,
session.
thank you very much.
So
Over to you, Hadel. Yeah.